All right, we're now on section 8 of our axial and appendicular muscles. We're now talking about the muscles of the pectoral girdle and the upper limb, also referred to as the shoulder girdle. What are the functions of the pelvic floor muscles? The primary question or objective for this section. Oh, went too far. Also, I should say there was more than just the one there. Describe the muscles that pronate and supinate the forearm. Describe the muscles of the anterior compartment and their actions. Identify the layer in which each resides. Explain the actions of the muscles of the posterior compartment and identify the layer in which each resides. Compare the actions of 3 groups of intrinsic muscles of the hand. As far as the anterior thoracic muscles, for that region for the pectoral girdle, we have the pectoralis minor, which is deep to the pectoralis major. It helps to press, pin down your shoulders and protract the scapula so the shoulders protrude forward and hunches your shoulders essentially. And this muscle does something similar. Basically, the serratus anterior, or serratus anterior, some will say, the fan-shaped muscle between the ribs and the scapula. It also protracts the shoulders and helps stabilize the scapula as well. Subclavius extends from the clavicle to the first rib, and it stabilizes and depresses the scapula. And so we have here in our images here, for the superficial side, we have our deltoid here, one of the heads of our deltoid. There are 3 heads of that deltoid, right? We look at the anterior essentially here. Pectoralis major is a fan shape, and as we will talk about, or as you should know from a general perspective, not so much for testing, but you should know to be able to identify function of muscles. Again, we're roughly where a muscle originates and where it inserts, and the pectoralis major actually originates on the humerus and inserts across up into the clavicle, across the sternum there, and a little bit in the ribs. The biceps brachii is a long head, the biceps here. It's really the primary mover really in elbow flexion, not so much the brachialis like is often stated here. And the sternocleidomastoid, part of our neck muscles that help flex that neck and also help stabilize that neck. Subclavius here, between basically the upper rib there and our clavicle. Subscapularis here, related to, of course, the scapula and the humerus. Our coracobrachialis, playing a relationship here with the humerus here, as well as the coracoid process of the scapula. Our pectoralis minor here, and a serratus or serratus anterior throughout these ribs and across. The posterior thoracic muscles, levator scapula, or scapulae, which attaches to the cervical vertebrae and the scapula. It elevates and inferiorly rotates the scapula. Okay. Rhomboid major and rhomboid minor runs inferolaterally from the vertebrae of the scapula. It's deep to the trapezius, helps elevate, raise them up, retract, pin them back, and inferiorly rotate the scapula. Often referred to as more as medial rotation coming in together. Trapezius, or actually across, coming across and in front. The trapezius is a diamond-shaped muscle extending from skull in the vertebral column to pectoral girdle. Can elevate, depress, retract, or rotate the scapula. And really, other than inferiorly rotate, we really should say adduct as opposed to inferiorly rotate to make that clear. There's a lot of different terms used for similar concepts can be confusing at times. A lot of texts, a lot of sources will say the same thing with different wording, which can be confusing, but they're really saying the same thing. And then take a look at our muscles down to the pectoral girdle for the posterior view and the glenohumeral joint in the arm there. Our trapezius, upper region of which elevates our shoulders primarily, middle trapezius region, which would be more across in here to help retract the scapula, and lower trapezius more for depression of the scapula. Rhomboid minor here, coming across, is also still going to help pin down our shoulders here. Rhomboid major, or retract and actually bring back our shoulders. And then a deltoid, this is the posterior deltoid, which is actually more responsible for shoulder extension, bring the arm down, as well as horizontal abduction, a little bit coming across, but mostly extension of that shoulder there. And there are deep fascia covering the infraspinatus here as well, and our latissimus dorsi, which actually begin at the pelvis and come all the way up into the humerus here, and help pin the shoulder blades down, depressing them, depressing your shoulders, as well as adducting the shoulder and extending the shoulder. Levator scapula, more for elevation of the shoulder here, originates up here and it attaches here and pulls up toward cervical, the base of the neck here. Supraspinatus, and then infraspinatus, teres minor, and actually subscapularis, which was over here, wasn't? No, we're not showing in this picture, are our 3 or 4 total sits or rotator cuff muscles: supraspinatus, infraspinatus, and teres minor. They all have their own independent functions, but together they stabilize the shoulder. The job of the rotator cuff is to stabilize the shoulders, plain and simple. Teres major or teres major has a roughly similar role to the latissimus dorsi. It's just not a primary mover, more an assistant mover. So here we have retracted scapula, good posture. Really good posture is actually not retracted, it's actually neutral posture, so that's a little bit overstated. But a lot of people typically have protracted forward shoulders or protracted scapulae, consequently having poor posture. So good posture would be from that position, retracting backward. But technically this is really just anatomical neutral here, with the hands facing each other when the palms turn open. It's anatomical position. Pectoralis minor and serratus anterior play a role with protraction, showing the shoulders kind of pushing forward there, so to speak. The arm does not necessarily need to be up, but it plays a role in assisting for greater protraction of the shoulder there. Retractors, or middle trapezius plays a role with retraction, as well as the rhomboids do. And of course, the protracted scapulae, poor posture, serratus anterior might pull you forward, or the pectoralis minor might do so to some extent as well. And then here we have, we'll get a little closer here. So we have the muscles that actually elevate the shoulder. We have our rhomboid major playing some role with that, and rhomboid minor playing some role with that. But they're also more retractors than they are more elevators. And that said, levator scapulae does play a role with elevation more. Trapezius, the superior part, also known as the upper trapezius, plays a role with elevation. Depressors, or lower trapezius, are also referred to as the inferior part. Pectoralis minor plays some role with depression, but really a bigger depressor that's not even mentioned there, surprisingly, is latissimus dorsi. It plays a much larger role with depression than does the pectoralis minor. Our superior rotators are basically the higher level one's higher on the shoulder there. Serratus anterior play a role with rotation, and trapezius, the superior part, plays a role with rotation to some extent too. Inferior rotators, or rhomboid major, rhomboid minor, play a role with rotating, coming back, and as well as levator scapula play a role there as well. Muscles that move the glenohumeral joint in the arm. There are 11 muscles that cross the glenohumeral joint and move the humerus. The prime mover is the glenohumeral joint, and I think one of the reasons why the last picture was, of course, showing it, they're only referring to the scapula, but depresses the shoulder girdle as a whole. Latissimus dorsi plays a much greater role. It's a broad triangular muscle on the back. It's the primary arm extensor, but really, and I want to make sure we give clarification here, it really isn't ideal to be referring as arm extension, because really when we refer to motion, really refer to the joint, not so much the limb or the whatnot. So a lot of people refer to thigh, or they'll refer to leg and it should be knee or hip. Refer to arm and it should be shoulder. Okay, and often refer to forearm, it should be elbow. Refer to the joint. So I left it the way it was reported here, it's the way it's worded in the text, but really, when we say arm extension, it really should be shoulder extension. That's what we're talking about here for latissimus dorsi, as well as shoulder adduction, bringing the shoulder down in the frontal or coronal plane, and medial rotation, also referred to as internal rotation of the arm. And pectoralis major has a thick fan-shaped muscle on the superior anterior thorax. It's not really a primary arm flexor. It plays some role in shoulder flexion, not a significant role, actually. It's really more of a synergist with arm flexion. It's a lot more toward the deltoid, playing a role with that in the biceps brachii. It's really not that much for pectoralis major, although it's some. However, horizontally adduction, not adduction per se, but more horizontal adduction and internal rotation we're talking about here. They should say horizontal adduction. Again, I left it the way the text referred to it, but really it's horizontal adduction, coming across transverse plane, not so much just not coming down so much. There's very little involvement of adduction for the pectoralis major. Triceps, that's a lot more lats that do that job. Triceps brachii, the long head originates on the scapula, and it spans the shoulder joint, helps extend and adduct the shoulder, referred to as arm here. Actually, really, that's not even, for the triceps brachii, the long head, so it does that. But the triceps in general, though, are more for elbow extension. Okay? The extension of the elbow and the long head helps extend and adduct the arm, but even that's questionable. It's really more toward extension. Biceps brachii, both heads originate on the scapula and span the shoulder joint. It assists in shoulder flexion as well as elbow flexion. Okay? The deltoid, and this is where it's important that you're looking at the words here, but you got to be hearing what we're talking about, because we want to be able to differentiate the way it's stated in the text that's being more clarified. The deltoid, 3 heads, The primary abductor of the shoulder / referred to arm here. Its anterior fibers flex the shoulder and internally or immediately rotate that shoulder or arm. Its lateral fibers, basically abduct, bring your shoulder out to your side. People would call them lateral raises. They abduct the shoulder. Its posterior fibers extend and basically externally, also called laterally, rotate the shoulder. The coracobrachialis basically is involved in shoulder flexion and adduction of that shoulder. The teres major extends basically the shoulder to some extent, and adducts and medial or internally rotates the shoulder or arm, essentially the same role again as latissimus dorsi, although it's a synergist, not a primary mover in those motions. Rotator cuff muscles, we have our subscapularis, the only one of the four that actually rotates the arm internally / medially. The supraspinatus abducts the arm, brings it out to the side, again like a lateral raise, but again more of an assistant, whereas the deltoid would play the primary role, the lateral or middle head will. Infraspinatus and teres minor both adduct and laterally or externally rotate the arm together. The SITS or sits, or subscapularis, infraspinatus, teres minor, and supraspinatus are your rotator cuff stabilizers. So it should say primary job of the rotator cuff is to stabilize the shoulder. These are all independent actions. So here's your rotator cuff. It doesn't really, the subscapularis helps wind up for the pitch. Supraspinatus helps in executing pitch delivery. Well, they all help in executing to some extent. Infraspinatus and teres minor slow the arm at the end of the pitch, but from a standpoint of overall, the rotator cuff itself stabilizes your shoulder because altogether they're trying to perform their independent actions, and now when they are firing, you're helping shoulder stay stable. Here being the clavicle, and our acromion process, the clavicle here, the supraspinatus coming across here, and our coracoid process of that scapula here, subscapularis, and of course being the humerus. Here's our supraspinatus, infraspinatus, and the teres minor. From a clinical view, our rotator cuff injuries are the result of trauma or disease. They can be caused by repetitive use. They can be caused by falling on the shoulder or lifting too heavy of an object, because of the inability for the four muscles to help stabilize that shoulder properly. Supraspinatus is most commonly involved, well, typically more because there's a lot of danger with a lateral motion, kind of raising arm to the side. You're not real strong there because there aren't many muscles that play a big role there. That's why it's most commonly involved, but really it could be any of the four playing a role with injuries for the rotator cuff. Symptoms are swelling, tenderness, and pain with movement, because obviously you can be tearing tissue there. It's especially common in baseball players because that common throwing action over and over again. Repetitive use, if there's not enough balance there with strength and proper mobility as a whole that's developed on top of the basic skill of throwing, not to mention how hard someone is throwing or how long someone may be throwing for, can play a big role with a lot of issues with the shoulder. It's almost inevitable for a person who pitches for 10, 15, 20 years to have rotator cuff injuries. This may require physical therapy or surgical repair. We're going to come back to the arm and the forearm muscles and the elbow as well here shortly.